Bismillah ar-Rahman ar-Rahim. Good morning. I'll have the pleasure to introduce our first speaker, Dr. Jeffrey Robens. Dr. Robens is the Editorial Development Manager at Nature Research, and he's responsible for conducting the Nature Research Academist Training Workshop to improve publication output all over the world. He has strong scientific qualifications with 20 years of academic experience and numerous publications and awards. He received his PhD from the University of Pennsylvania and then worked at premier research institutes in Singapore and Japan. Since leaving academia in 2012, he has conducted over 250 academic training workshops across Asia and the Middle East. These workshops to help researchers to improve their publications' quality and impact. So, Dr. Jeff, please. Just a word, I'd like personally to thank everybody from the organizing committee and scientific committee for doing that great job. And of course, this was with the leadership of Professor Ahmed Sheikh, the chairman of the Department of Anesthesia. Thank you very much all. Dr. Jeff, please.
Okay. Can everybody hear me okay? Okay. Well, first of all, thank you very much for the kind invitation to be here today. It is certainly a pleasure. And I would also like to thank all of you for taking time to be able to attend these workshops and seminars. So I would like to talk about the gap between research that's being conducted and the actual clinical practice. Before I do so, why would I be interested in discussing this sort of gap? Well, I work with Springer Nature, and as we publish over 3,000 research journals, many of them in clinical research, it is important for us as publishers, the research that we publish is in fact having impact on clinical practice. So we publish over 12,000 books. You may be familiar with some of the imprints that we have, such as Nature, Biomed Central, Springer, ATIS. So when I was asked to discuss, does this gap exist? I thought a better question, I probably in a better position to ask, is why would there be a gap? There is a lot of available research. There's a lot of research being conducted. So why would there be such a gap? Well, a lot of this is likely due to publication bias. And I'll be talking about this quite much in this lecture today. There's also going to be problems with discoverability and visibility. If you cannot find the research, how are you supposed to know how to implement it in clinical practice? And there's also an important problem with reproducibility, transparency in clinical research. And this will be the subject of my second lecture into this morning's workshop seminar. So first I want to talk about publication bias. Now for those of you who are not familiar with what this means, it simply refers to the fact positive results will almost always have a better chance of being published than negative results. Now, does this mean that negative results are not useful? Of course not. All results are going to be important to understand in terms of the clinical efficacy of various interventions. Not just the ones that show that the intervention works, but equally the ones that show the intervention does not work or has significant problems that you need to be aware of if you want to implement these interventions in the clinic. So that means most readers will not be exposed to all of the available evidence. just a selected part of what actually has been completed. And I think this is going to be a contributing factor into the gap between what is known and how it will be clinically useful. This bias is something that is very important from both a clinician's perspective, but also from a publisher's perspective as well. So why would such a publication bias occur? If researchers are spending a lot of time, money, resources to try to investigate the efficacy of a novel intervention, why would they not publish it? What are the contributing factors? Well, for authors, they may be less likely to want to take the time to write a paper and submit it for publication. So authors want to ensure that they're going to take time out of their busy schedules, that they're going to have a high likelihood of having that research published. Furthermore, when people want to publish their clinical research, they're doing so to have influence, to have impact. They want to build their reputation with their peers worldwide. And they know the best way to do this will be with positive results. Furthermore, they do understand that they'll probably have administrative pressures from their institutions or hospitals. They will be assessed in terms of the research output that they have. They'll often be assessed by the impact factors of the journals that they publish in. Therefore, to help improve their assessment, which is going to be leading to their careers, they may be more prone to only want to publish positive results. But of course, the problem is not simply with authors. Us in the publishing industry also are to blame. Journal editors are also trying to improve their reputation. They know they can do that if they're publishing research with more positive results. These will likely be more highly downloaded, more widely cited, building the impact factor of our journals, building the prestige of our journals in the field. Because we know when we are more prestigious, we're able to attract higher quality research. Therefore, this publication bias has two different sides, from both the author's perspective, but also, of course, from the publisher's perspective as well. So is there a publication bias in anesthesiology? So there's an interesting research that was published last year to evaluate, are research being done, randomized controlled trials in anesthesiology, are they actually being published or not? So what these researchers did, they evaluated over 1,000 abstracts over a 4-year period from the American Society of Anesthesiologists annual meeting. Now, because these are abstracts, these are not yet published randomized controlled trials, so they thought this would be a good suggestion of what is currently being done, and then they followed these abstracts for a period of 10 years to see how many were actually published in PubMed indexed journals. How many were found to be published? Well, only 53%. Just a little over half of what was presented at these conferences ever made it to the published literature. And this is very consistent with the evaluation of unpublished randomized controlled trials in many other fields as well. So this is, for me, not very surprising. About half of what is done is never made publicly available. That will lead to an important gap in your knowledge of how to implement certain interventions in the clinic. They also wanted to know, was there a bias between positive and negative findings? So from these abstracts, they could see, was the intervention useful or not? And then when they tried to calculate, they found that yes, there was a significant bias in the publication of positive results over those from negative studies. So the relative risk they found was 1.42 in favor of positive results. So this is consistent with what is known throughout clinical research. It is also a current problem in anesthesiology as well. That means you will not be made available in terms of all the available evidence that is known about certain interventions. And that could be problematic. So, to help prevent the publisher's problem with these positive results bias, some journals are starting to implement a new submission strategy called registered reports, which is standardized by the Center for Open Science in the UK. BMC Medicine is the first clinical journal to implement this. Way that this type of submission works is in two stages. First stage, you as the author or as the researcher would prepare your introduction and methodology only. So before you begin the research. And then you submit this for review. It will be sent out for peer review by experts in the field. And if they agree your research question is important and valuable to the clinical community, if they agree the study design is appropriate, and they agree with how well you have designed the actual study itself in terms of robustness and reproducibility, then they will give what's called an in-principle approval, meaning as long as you adhere to what you say you're going to do, and you don't change the outcomes or change the study design, the paper will be published. The whole idea then is to publish research based on the quality of the science, not on the positivity of the outcomes. So this was just implemented by BMC Medicine a couple of months ago. So it is a very new strategy to overcome publication bias, to ensure that all of you will be exposed to the available evidence in anesthesiology and other clinical disciplines. Hopefully other medical journals will follow suit, and hopefully this will help close the gap between research and clinical practice. So I wanted to evaluate, and from my own perspective, how many RCTs that have been registered and completed in clinicaltrials.gov ever went to publication. So this is my own personal, not a very thorough evaluation, but I did look at a variety of different types of RCTs with this search string, only looking at those that are either completed, terminated, or withdrawn, meaning they are no longer being conducted, phase 2 through phase 4 RCTs, where the last update was at least in 2014. Why? Because it generally takes about 3 years to publish research. Based on all of these, I was able to find in anesthesiology in this 10-year span about 3,400 registered RCTs. Now there are, of course, other registries that are available. This is the largest one, and this is why I use this. So there will be, of course, a sampling bias. This is the distribution of the RCTs in that period in anesthesiology. Maybe not surprisingly, the United States and Western Europe take up the bulk and the majority of these RCTs. When we evaluate Africa, we do see that Egypt is second in Africa, following South Africa in terms of the number of registered RCTs in this 10-year period. So I now wanted to use that same search string in Web of Science, which are the impact factor journals, to see how many of them were ever published in these impact factor journals. What I found, 807. So out of the 3,000 RCTs that were registered, only 800 of them made it into Web of Science. Now there are, of course, non-impact factor journals they could have been published in. So there is another selection bias here. But these being the higher quality medical journals, I decided to use this for my analysis. These are the number of RCTs in anesthesiology that have been published in Web of Science during that period. You can see a nice increase every year in the number of these RCTs, which is good. In terms of the countries, the United States leads the world with 176. Egypt was 23 with 13 RCTs published in Web of Science over this time period. So then I went back to the 21 registered Egyptian trials in clinicaltrials.gov to investigate how many of these 21 ever made it to publication. I used both PubMed as well as Google to try to evaluate based on the trial registration number. Google would, of course, look at both indexed and non-indexed journals. Unfortunately, I could only find 2. Now, I'm not sure if these 2 groups are present at the conference today, but I would like to commend these people for not only ensuring that their research was registered in clinical trials before they began, but they also ensured they published these trials upon completion. But you can see there is still a very large gap in terms of what is being done and what is being made publicly available to all of you. Because most clinicians will not be searching what we call the gray literature, unpublished completed trials, to see what is known about an intervention. Many of you may only rely on PubMed index journals to be familiar about what is being known about a certain intervention. And by having this lack of discoverability, you will not be made available to all of the evidence related to that treatment. So just because it's published, does that mean it is discoverable? And the answer is, of course, no. So there are problems, of course, with the discoverability. Many people, particularly if they're more negative related results, will not have an opportunity to publish in index journals. They will choose non-index journals that are more lenient in the review process. Or they may be published in index journals, but because of poor choice of keywords and search engine optimization, they are not easily visible when clinicians go online to try to find it. So this is another study that was trying to evaluate publication bias in anesthesiology. But what their question was is how high impact factor journals would affect if it's positive results versus negative results. So they looked at over 1,100 RCTs published in 14 anesthesiology journals between 2008 and 2009. They found the odds ratio for positive results to be published in high-impact anesthesiology journals was 2.28. So over 2 times more likely to get published in high-impact, well-respected, reputable anesthesiology journals when they have positive results. And because these are the journals that most people will refer to when they're trying to find what is the available evidence, they're simply making the gap larger than it needs to be. So if you want to improve your discoverability of what is known about a particular intervention, you need to do more to try to close this gap at a personal level. So you have to be familiar that those papers that are published in more high-impact journals or Medline impact journals are likely going to be biased towards positive results. And as most clinicians often refer to these journals, that means they're simply not aware of the more negative results. They may impact the implementation of certain interventions in the clinic. So you should try to be more broad in terms of evaluating the available evidence, not only looking at the higher impact, high prestigious journals, but also the lower impact or newer journals in the field. You may also want to expand your search from only looking at PubMed to also using Google Scholar, which would look at non-indexed journals. But you also have to be careful. Many of these non-indexed journals could be predatory journals. Predatory journals are these journals that are illegitimate. They're not real publishers. They do not use peer review to publish that results. So if you ever are looking at an RCT that has been published in a journal you are not familiar with, that is not indexed in a database that you can trust, you know you need to be extra careful in evaluating the reliability of that evidence. You can be using different assessment tools from Cochrane database, for example, or the Equator Network checklists, so you can then determine whether or not the data reported in those articles are reliable and trustworthy. And of course, you should always be up to date on systematic reviews and meta-analyses, because that is exactly what they aim to do, is to synthesize all the available evidence, published and unpublished, where they have independently evaluated biases and reliability of that data, and then synthesize it either in a narrative or statistical way for clinicians. So systematic reviews are an excellent way to help to close this gap between what is known, the available evidence, and clinical practice, but that means you do need to take the steps to find it online. And so with that, I'd like to thank you for this first lecture of this morning's symposium. Thank you.